This is Bart McDaniel doing a 12-lead EKG interpretation based on Dubin's method. So, a sample EKG here on the screen, and we'll start with determining the rate. So, if we'll look at the strip across the bottom, lead 2, we will use the big box method, counting between the QRS complexes. 6. I do not see any. Is just barely under 75 beats a minute. So then we'll look at rhythm, the R to R distance. We measure that, and they are and leads V2 through V5 all show ST elevation, and this is indicative of anterior wall involvement, any ST depression, and we see some in 0.2. So this tells us that we have a regular full lead. Then we'll look at any axis deviation. So we'll look at leads 1 and AVF, and the QRS complex in both of those are upward, which is positive, and that tells us there is a normal axis. So overall, we also look at T waves, any T wave inversions. So lead 1, 2, 3, AVL, AVF, B1 through B6, a little less than 3. So we'll just use 3 big boxes as the height of the S wave, and then V5, the R wave height is almost 3 as well. So you add those together and you get 6 big boxes, and that's less than 7 big boxes, which tells us there's no left ventricular hypertrophy. Then we'll move on to any injury or infarction or ischemia. We'll look at any pathologic Q waves. We'll go through all leads. So 1, 2, 3, AVL, AVF, V1 through V6. I do not see any pathologic Q waves. We'll look at ST elevation and depression. There's a little elevation in 1 lead. AVL has some, and leads V2 through V5 all show ST elevation, and this is indicative of
interval here, indicative of a block. It is longer than 0.2 seconds, and have a widening again and more until it eventually drops a beat here. So looks like we have a winky
leads for the anterior lateral infarction or injury, and this
is a sinus rhythm. Next, we're going to look at
overall. We also look at T waves, any T wave inversions. So lead 1, 2, 3, AVL, AVF, B1 through B6, and there's no T wave inversions. So we have a normal sinus rhythm with a rate of around 70, showing signs of anterolateral infarction or injury in the anterolateral walls of the heart, involving the LAD, circumflex, or the obtuse margin.
Significant axis deviation between -30 and +105. We're going to look over V1, V5 for hypertrophy, left ventricular hypertrophy. We're going to add up the little blocks. So say 1, 2, 3, 5, 8, 10. Looking at the small boxes of the if we look down here at lead 2 in our rhythm strip, we do see that there is some regularity with these first few beats of the QRS. However, and next is infarct injury, we're gonna start by looking for any ST elevation, which we do have. Our inferior leads 2, 3, and AV. As we can see here, T waves, they are normal. We have, looks like we have a Winky Bach. Next, we do have a P wave for every QRS, so we know that this, and judging by the rate, a little bit or about 90, that it is a sinus rhythm. Next, we're going to look at the QRS. QRS, looking here, it looks less than 0.12, so QRS is normal. Let's see. We don't have any U waves, so no hypokalemia. Next, we're going to look at axis. So we have positive deflections in lead 1 and AVF, showing that we do not have any significant axis deviation between -30 and +105. We are going to look over V1, V5 for hypertrophy, left ventricular hypertrophy. We're going to add up the little blocks. So say 1, 2, 3, 5, 8, 10. So looking at the small boxes of the R and S waves, V1 and V5, they add up to less than 35 millimeters, so there's no left ventricular hypertrophy. And next is infarct, ischemia, injury. We're gonna start by looking for any ST elevation, which we do have in our inferior leads 2, 3, and AVF. As we can see here, T waves, they are normal. We have them positive in leads 1, 2, and V3 through V6 here. Next, Q waves. See if we have any pathological Q waves. So this here looks a little questionable with this first negative deflection, leads 25% of the R wave here. However, in other leads, you can see negative deflection, evidence of some negative deflection. So this being questionable here and not being in any of the other leads with a pathologic Q wave, especially in the ones that we're looking for infarct here. I don't think we can conclusively say that it is a pathological Q wave. However, we do have a significant second degree type 1 AV block. We have a Winky Bach. It is a sinus rhythm, like we said, and an inferior wall injury by the reciprocal changes in our lateral leads 1 and AVL here with the ST depression. So it looks like lateral wall injury. Can't really say MI yet, just not judging by just these three beats with nothing else that shows in our other leads, and most likely involvement of either the right coronary artery or circumflex. And that concludes our 12-lead interpretation with Dubin's method. Dan Walker and Bart McDaniel.